Supraventricular ectopics are the commonest form of supraventricular arrhythmia. They can occur in isolation or in sequences of couplets. If more than three are seen in a sequence, it will constitute a short run of supraventricular tachycardia. Supraventricular ectopics are common in the setting of atrial dilatation due to chronic obstructive lung disease or left ventricular dysfunction. Supraventricular ectopic beats have a narrow QRS complex preceded by an abnormal P wave. Sometimes the P wave is not visible if it is hidden within a QRS complex or T wave. The ectopic beat is followed by a compensatory pause, which is classically not fully compensatory, unlike a ventricular ectopic beat. ECG strip showing a supraventricular ectopic beat with a narrow QRS complex and no evident P wave preceding it. It is followed by a pause which is not fully compensated. Interval from previous sinus beat to the ectopic beat is known as coupling interval. If it is a fully compensatory pause, the sum of the coupling interval and compensatory pause will be twice the regular RR interval. Here it is slightly less. This is because the supraventricular ectopic beat penetrates the sinus node and resets the sinus cycle. The difference in the length of the pause from the sinus cycle length depends on the time taken for the supraventricular ectopic beat to travel up to the region of the sinus node, at which point the sinus cycle restarts. The pause can be lengthier if there is suppression of the sinus node activity by the ectopic discharge, as seen in sinus node dysfunction. Supraventricular tachycardia can be recognized on the ECG as a narrow QRS tachycardia with either absent P waves or P waves which are distinctly different from those in sinus rhythm. Often P waves are not visible in supraventricular tachycardia because the commonest form is atrioventricular nodal reentrant tachycardia, in which P waves are masked by the QRS complex. A scrutiny of the terminal portion of the QRS complex will reveal retrograde P waves, which will be inverted in inferior leads and positive in V1. These have been called pseudo S and pseudo R prime waves in supraventricular tachycardia. ST segment depression is common with supraventricular tachycardia and it need not indicate associated coronary artery disease. Atrial repolarization wave, which is not visible in a usual ECG, could become prominent during supraventricular tachycardia and contribute to the ST segment depression, which is often associated with it. Post-conversion ECG is usually normal unless there is associated ventricular pre-excitation like Wolff-Parkinson-White syndrome or WPW syndrome. It is mandatory to get post-conversion ECG to check for pre-excitation. Supraventricular tachycardias have been classified into long RP and short RP tachycardias depending on whether RP interval is longer or shorter than PR interval. Typical form of AVNRT is the commonest form of short RP tachycardia, but P waves are visible only in 20% of them. ECG showing supraventricular tachycardia with narrow QRS complexes. ST segment depression in inferior and lateral leads need not indicate ischemia. Pseudo S and pseudo R waves due to retrograde P waves are visible. ECG diagnosis of supraventricular tachycardia becomes difficult when it is associated with aberrant ventricular conduction, as it appears as a wide QRS tachycardia. It may be noted that wide QRS tachycardia is usually taken as ventricular tachycardia unless proved otherwise. If typical right bundle branch block pattern is seen as in the illustration which follows, it is easy to make a diagnosis of supraventricular tachycardia with aberrancy. Otherwise, it is often difficult to make a diagnosis of supraventricular tachycardia with aberrancy, especially in an emergency. When in doubt, it is better to treat by direct current cardioversion if there is hemodynamic compromise. Diligent search for dissociated P waves, if found, could favor a diagnosis of ventricular tachycardia. But this is often difficult in a fast rhythm, which could be further confounded by frequent artifacts in a restless person. Diagnostic use of adenosine has been recommended but is not totally without risk, as rarely adenosine-associated ventricular fibrillation can occur. ECG showing supraventricular tachycardia with aberrant conduction indicated by right bundle branch block pattern with terminal slurred R in V1 and terminal slurred S in lead 1. Atrial flutter with 2:1 conduction is an important differential diagnosis for this ECG. Vagal maneuvers can be used to slow the AV nodal conduction and alter the conduction ratio to bring out hidden flutter waves if any. In case of true supraventricular tachycardia, these maneuvers may terminate the tachycardia. Same is true of intravenous adenosine, which induces transient AV block in a more predictable way. The prominent R' and S wave in this case are different from the tiny pseudo R' and pseudo S due to retrograde P waves. Supraventricular tachycardias can be classified into atrial and atrioventricular depending on the region of re-entry. It can also be divided into regular or irregular, with atrial fibrillation being the commonest form of irregular tachycardia with a supraventricular origin. The QRS complexes can be narrow or wide when there is aberrant ventricular conduction or pre-excitation. SVTs can also be divided into AV node dependent versus AV node independent. Another form of classification of SVT is into short RP versus long RP interval tachycardias. Tachycardias with atrial circuit are sinus tachycardia, sinus node reentrant tachycardia, atrial tachycardia, multifocal atrial tachycardia, atrial flutter, and atrial fibrillation. The different types of atrial flutter are typical, reverse typical, left atrial, atypical, and scar-related atrial flutter. Upper loop reentry, lower loop reentry, and figure of 8 reentry are other descriptions of the circuits in atrial flutter. Tachycardias with atrioventricular circuits are atrioventricular nodal reentrant tachycardia, AV reentrant tachycardia, and junctional ectopic tachycardia. AV NRTs themselves can be of 3 types: typical, atypical, and the slow varieties. In the typical variety, anterograde conduction is over the slow pathway and retrograde conduction is over the fast pathway. Hence, the initiating premature atrial complex will have a long PR interval. The RP interval is short, that is short RP tachycardia in this variety, with PR more than RP interval. P wave is either within the QRS or at the terminal portion of the QRS. These P waves manifest as pseudo S waves in inferior leads and pseudo R waves in V1. In atypical AV NRT, the opposite pattern of activation is seen, so that RP is more than the PR interval, long RP tachycardia. In the rare slow pathway tachycardia, the re-entry occurs between 2 slow pathways. Atrioventricular reentrant tachycardias can be divided into orthodromic and antidromic. In orthodromic AVRT, the anterograde conduction is through the AV node and the QRS complex is narrow. Orthodromic AVRTs contribute about 90% of the AVRTs. Antidromic AVRT has the reverse pattern and the QRS is wide and bizarre. Junctional ectopic tachycardia is due to enhanced automaticity of the AV node and can manifest AV dissociation in the ECG with a narrow QRS. It can be congenital as well as acquired. It can occur in the setting of cardiac surgery and response to cooling, that is induction of hypothermia. Usually it is difficult to document the initiation and spontaneous termination of an arrhythmia. This is because the arrhythmia is already there when the person presents to the emergency department. Termination is most often achieved by vagal maneuvers or by medication. If a monitor with recording facility has been deployed during this period, it is possible to get the tracings of termination. But many a time in an emergency setting, recording part is forgotten and only monitoring is done. Getting a record of initiation and termination gives useful insight into the mechanism of the tachycardia. This is a monitor screenshot showing initiation of SVT by a supraventricular premature complex. Sinus rhythm with normal PR interval is seen in the initial beats. A supraventricular ectopic, blue marker, is conducted with a long PR interval as the AV nodal fast pathway has not recovered fully after conduction of the previous sinus beat. This is followed by an echo beat, red marker. Supraventricular tachycardia can be seen subsequently. This is the sequence in typical AV NRT or atrioventricular nodal reentrant tachycardia of the slow fast variety. The sudden increase in PR interval with a supraventricular ectopic beat is equivalent to the PR jump noted during electrophysiology study and indicates dual AV nodal physiology. PR jump of 50 milliseconds or more is considered indicative of dual AV nodal physiology. Sinus beats have PR interval of 160 milliseconds as they are conducted down the fast AV nodal pathway. When the premature supraventricular beat arrives, the fast pathway is still refractory so that it gets conducted down the slow pathway, increasing the PR interval to 240 milliseconds. When the impulse reaches the lower junction between the fast and slow pathways, it finds that the fast pathway has recovered and travels back up the fast pathway. This produces the echo beat. Repetition of this sequence produces the reentrant tachycardia which follows. Diagram explaining the concept of dual AV nodal pathways. Fast pathway conducts fast but has a longer refractory period, hence it recovers late. Slow pathway conducts slowly but has a shorter refractory period and recovers soon. Monitor screenshot showing spontaneous conversion of SVT to sinus rhythm. Initial few beats are part of the supraventricular tachycardia. Termination of tachycardia leads to a short pause and ventricular escape beat, white QRS. This is followed by two narrow QRS beats, the P waves of which are not well seen, possibly low amplitude P waves or junctional beats. Next, white QRS complex is preceded by a P wave indicating a late diastolic ventricular ectopic beat. The QRS width of this beat is lesser than that of the previous ventricular escape beat. Hence, it could be a fusion beat combining sinus conduction from a P wave and ventricular ectopic. Finally, there is a good amplitude P wave followed by a narrow QRS after a normal PR interval indicating sinus rhythm.